Can you sit up, please? Okay. Can you look in the camera? Okay, this is very mean light, okay? This is coming from straight above, so we can see all the shadowing. Okay, let's have a look at her face. Can you zoom out a little bit?
Gentlemen, 1 second. Theory this way.
Yes, please. So, if we have a look at her face, we can see that... Oh, we're not yet connected.
There's no feed there.
There's no feed.
There's no.
Okay. All right. So we can start, right? Can you hear me? Can I have a thumb up?
Yeah, it's fine.
Yes? It's fine? Okay, good. All right, let's have a look at her face. And, you know, before we start focusing on everything that is wrong with her, maybe we can first say something nice to her. See what is actually looking very good on her face. So I think, you know, to focus on what is nice, like saying, you have a very good skin. That's actually one of the nice things you can tell your patient, and that will open up the door for suggestions of how you can improve the look on her face. So what is also very good is she has very good temporal volume. She has no temporal concavity here. And as you can see, she does have a little bit of a nasojugal groove, some festooning, and some tear trough. So actually, if we could like push up the deep medial fat compartment, then you can see that there's also already a reduction of the tear trough in this area. So another thing that we can look at is, of course, the nasolabial folds, but I think more importantly, and that is looking from the side, you can see that she's lacking projection of omentum. There is a very small chin, and I think we could very much improve her beauty by introducing some volume and getting more projection on the chin. And now that we're looking from the side, can you zoom in a little bit? Zoom to the nose. You can see this is the most, sorry, I'm hoping I'm not breaking your neck. This is actually one of the most popular indications. The Arabian nose hump, okay? Basically 3 possible areas to correct the nose, and this is the number 1 angle, number 2, and number 3. So to straighten the nose, we can just add a little bit of product here, just on the far side of the nose. You can't see it when I do it with my finger, but you will see it when I do it with radius. Okay, so please lay down and relax, and don't forget to breathe, all right? Sometimes patients forget to breathe when they're being injected. I will show you. Do you know how to mix the radius? You do? Okay. I will show you how to mix the radius, and I will shine the light a little bit towards myself. And you can see here is the syringe. I already removed the cap. This is the cap that was removed, and then I take a 3 ml syringe with, yes, with lidocaine, please, with 0.3 mLs of lidocaine. Also, when you buy radius, they will provide you with these nice little red lure lock connectors. You can attach 2 lure lock syringes to this lure lock connector. And so I will get the syringe with 0.3 mLs of lidocaine. Actually, it's got 0.4, so I will push it forward, so it's now 0.3. 0.3 mLs of lidocaine. I attach it to the lure lock connector, and then there is still air inside this system, so I have to remove this air by pushing a little bit on the plunger in order to get the drop of lidocaine at the surface of the lure lock connector. Now there is, excuse me, now there is no air in the system, so I can connect the syringe to the lidocaine syringe. And then I can start mixing. And as you can see, it's not homogeneous yet. So there's an FDA approval for mixing, and you have to do it at least 10 times in order to have a homogeneous mixed gel. So now it contains lidocaine, and it will be a little bit less viscous, but it will be more pleasant to inject for the patient. Thank you very much. Okay, has she been disinfected? Yes. Okay. I would like to have a marker, please. If you have a white marker, that would be great. So I usually work from top to bottom. And so let's have a look at her face again. You can move back and you can zoom in. And you can zoom towards the cheek area. Now, let's prevent any complications. The face has been disinfected, but the hair has not been disinfected yet. And so I'm going to be very close with my cannula to the hair. And you know, cannulas have so many advantages, but one of the disadvantages is that they are very long, and of course this is also an advantage, but the disadvantage is that it's easier to get contaminated. So I always want to have the hair above and in front of the ear wet. Then I will take my marker, and this is the treatment protocol. I will start with drawing a line between the ala and the tragus, which is called the alar-tragal line. And as you can see, above here there is periosteum, below here there is oral cavity. So as a general rule of thumb, above the line I inject deep on the periosteum, below this line I inject more superficial, subcutaneous or deep dermal. Now I like to draw the tear trough and the nasojugal groove. I like to draw the infraorbital rim, because the infraorbital rim, this is our limit. This is our area where we should not inject above, because then we get into the eye. Actually, it's more superior. It's over here. So over here we can feel the orbital rim. We're not going to go above the orbital rim. Also, we have to mark the infraorbital foramen. It's a depression just at the zygomatic bone, approximately 9 millimeters below the infraorbital rim, just medial to the mid-pupillary line. So, of course, we have to know that this is also a no-go zone. If you use needles, then you have to be aware of the arterial vasculature, and therefore this is generally regarded as a no-go zone. Now, if we want to go to the periosteal level above this line, we have to find a very nice entry point that gives easy access to the periosteal level. So I mark the inferior border and the superior border of the zygomatic arch. And over here is very superficial. I'm very close to the bone. So over here, just in front of the hairline, I have my first cannula entry point. From here, I can go over here, over here, over here, and even treat down to here. Sometimes when it's necessary, from this point, you can also treat the temporal area, which is not necessary in this case. So I will draw a vector line, because this is basically what I want to do. I want to pull back the cheek. So this is basically the vector line. It's going from the zygomatic arch towards the oral commissure. Now, this line is actually always the same, and it leaves this little triangle. So within this little triangle, I find my second entry point for my cannula. This is a great entry point, because from here, you can go with your cannula over the periosteum, between the infraorbital rim and the infraorbital rim. You can also treat the reduction of fat in the deep medial fat compartment. And if you wish, you can also treat superficial, but she has a pretty good skin, so she doesn't need so much skin tightening. Okay, I will also draw that on the other side, because we want to stay symmetrical. And here we go. 1, 2, 3. Sorry about that. I didn't mean to poke in your eye. So I feel for the depression, just inferior. Yes, you see the reaction. That means that it's at the good location. Then I mark the superior and inferior demarcation of the zygomatic arch just in front of the hairline. I draw my vector line towards the oral commissure. I see my little triangle, and I find my second entry point. Okay? So that's basically it. Are you cold? Is she cold?
Yes.
Yeah.
Okay.
No, come on, please.
Okay. So, I'm a little bit short. So for me, from this angle, it's a little bit difficult. But if we put the chair down, we can't see the injection because the camera is very far. We will see the inside of her nostrils, but not the injections. A step would be great. Thank you. Okay, so do you have some lidocaine with adrenaline, please? Yes, and put it in a 1 ml syringe, please. And with a 30 gauge needle. Do you have a 30 gauge needle?
Yes, yeah.
Okay, great. So we're going to, have a look at what we're going to do because we need the cheek to be lifted. And actually, I always want to take into account the OG curves and the optimum proportions. So from the orbital rim, if you want to go down from the orbital rim and you have the superior alar tragal line, you get to this. It's actually published by Arthur Swift. It's called Swift's point. It's right here. So this is a point where you can give her some extra projection in order to make her fit the golden ratio proportions better. You can also do that on this side. I feel for the lateral orbital rim. I move down, and the superior. So from the top of the ala, I draw a line parallel to my alar tragal line, and you get here to the beauty point, the sexy point, as it were, on the cheek. So I give her some local anesthesia. So what I like to do is, because I have one syringe, and I would like to have a little bit of an idea how much there is. So in one syringe of Radius, there is 1.5 mLs of Radius. So I added 0.3, so in total we have 1.8 mLs. So I will take half of that syringe, which is 0.9. Okay, so I will put 0.9 into my syringe, and I will attach the cannula. Oh yeah, that's it. I will attach the cannula. So, in the soft fill pack, there is also a 25 gauge needle. This needle is meant for making the pre-hole. Okay, I made my life a little bit easier with a bigger needle, but it is a little bit more risky for hematoma. So the next opening I will use the 25 gauge needle, which is of course safer, but if there is a blood vessel, you can always hit it. So I just put the tip of the needle into the skin, and when I take it back, I scrape the skin a little bit in order to make the hole a little bit easier accessible. Okay. Now, as I told you, this is a 50 ml, so it's 1, 2, 3, 4, 5 centimeters on the cannula. Now there's also a little dot, you can see here maybe, a little red dot on the cannula, which means that the opening is on this side. So if I press a little bit, you can see the radius coming out of the hole on the side of the cannula. You can zoom in to the cannula.
No.
Yes?
Yeah, to the cannula.
To the cannula.
What the heck, Brianna?
So you can probably see it right now. There's a little red dot here. You can see that the radius is over here at the exit of the lumen of the cannula. Okay. Okay, you can zoom. Yeah, that's perfect. So I'll make it better visible for you. So first I stretch the skin open in order to introduce my cannula easy. So after I've done this, I would like to go down to the periosteum. And of course the periosteum is below the smas. So I will, okay, I have to use the steps. Thank you. Okay, so I'm on steps. Usually I just put down the chair. So I go into the skin, and as you can see, to get through the resistance, I rotate, and then the cannula will wiggle its way past resistance. Now I want to go below the smas, so I lift up the smas, I pinch the skin, so I go deep down through the smas until I feel the glide plane of the periosteum. Now I'm right here, and I make sure that the opening of the cannula is facing towards the bone, because that's exactly where we want to have the radius. Now, I will inject one bolus over here. I will retract 1 centimeter, so I can use the marking on the cannula, and I inject one other bolus of 0.1. I retract 1 centimeter, inject one other bolus of 0.1. I retract 1 centimeter, I give another bolus of 0.1. And the last one is over here. 1, 2, 3, 4. Okay, that's still correct. 1, 2, 3, 4. So I should inject it over here. 0.05. Can I have a swab, please? Thank you. Okay. So I'm just checking if I don't see any lumps, if I don't feel any lumps, because the cannulas, the boluses are usually... Are you still breathing?
No, it's okay.
Are you okay?
She's okay.
Is it painful?
Little.
Really?
إنه في وجع شوي ما
ايه طبعا
في.
هو مخدرك بس مكان الابره، بس على سحب الماده ما بصير.
بس حسيت هيك في شيء.
اي عم يحرق معك.
هاي المادة. Okay.
Okay, so I forgot to remind her that she can breathe during the procedure.
اثناء ما عم تشتغلي لازم تتنفسي وترتاحي.
Okay. This is also another reason why it's good to have the patient more in recline. Because in recline, you have more blood pressure to the face. Can I continue?
Yeah.
You sure?
Yes.
Okay. Because if you're not sure, we can wait, you know, I can treat somebody else. I can see somebody else who needs treatment. Okay, so...
Your hand is coming to the camera. You're not able to see.
So, I want to go below the smas, so I lift up the smas. Sorry about this. I lift up the smas, and I go with my cannula below it. And if there's resistance, I rotate, and then I can get through. So now I just go just to the infralateral side of the orbital rim and on the periosteum. So make sure that the opening is facing downwards, and over here I don't give boluses because the tissue is much thinner. And, you know, giving retrograde linear threads, just, you know, at the infralateral side of the orbital rim, because we know from research by Robert Shaw that the bone resorption at the infralateral side of the orbital rim is the most dramatic, the most important. Okay, now I get to below this line, and I will give some retrograde linear threads in a more superficial plane. So actually this is just to induce neocollagenesis. And now, of course, I want to be closer to the skin. So I put the bevel, I put it up, and I give 1, 2, almost 2 retrogrades. Okay. So keep on breathing. You know what? Maybe now you think, what am I doing here? Okay? After the treatment,